Oh.
Yay!
That's what I'm thinking, yeah.
Don't get me wrong, I love coming in here.
It's all the Saturdays that I can margaritas for lunch.
Yeah, you can't drink. Get you some red drink.
Actually, does that put the sword?
I need
Boy, oh boy, oh boy.
What about the waste all that? There was everything was in it.
I've got July 30th is when you are, the second, you are, third is my first ride out. And then 7th, 9th.
Why are you talking about yourself like that?
I know. Because I couldn't get this thing to open. I was the wrong door. Put this thing closer to my vocal cords. That's that little sissy voice. I hate my voice being recorded. Sounds so feminine.
What's wrong with this?
Why don't you take that with you?
No. One end is apparently
Huh?
maybe now.
La 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 la.
Oh yeah, that's right.
Where you going, redneck? What boy just got here?
He's tiny, he's got a little butt.
He's trying to do what?
I said he's tiny. And
I know. All right. This is probably the last one in as far as the body parts and stuff goes. This section is burns, and you guys mentioned there's a lot of questions on the quiz about this. Okay. So, well, I suspect you see some of these questions on the test then, so I'll try, if I can remember them, I'll kind of go over them. Phil did soft tissue injuries the other day, is that right? So some of this is repeat of what he said. You guys probably know it's the largest organ, and it has a lot of meaning. I mean, it does a lot of stuff. It keeps, like, things like that. It helps to retain fluid. People that have severe burns get in trouble real fast, don't they? They do. And so, and it's because they lose what part of their blood? The plasma, exactly. And can you go into shock from that?
yes.
What kind of shock? Okay, I'll buy that. Okay. The other thing it does, because of protection, are they apt to get a pretty nasty infection? And the other thing is because of the temporegulation part of it, they get hypothermic pretty quickly too. So there's a lot of stuff going on when you have somebody that's got burns. You guys talked about this, and Phil probably pointed out that when you get down to the subcutaneous level down here, when you get down to that, that's where the base of the nerve endings are. And there's kind of an old adage that we use: first and second degree burns probably produce quite a bit of pain, and if you have a true third degree burn, it's not very painful at all. What I want to remind you of, though, is that you're always going to have some kind of pain with burns. Okay, in fact, you're probably going to have a lot of pain with burns. Sometimes you see patients that have significant third-degree burns, and if this whole arm right here has got third-degree burns, then that's probably going to be painless. Okay, and that again is because the nerve endings have burned down to that third layer. So, as we look at this, can we say, for example, that the outer layer of skin, if we have a burn, like a sunburn, can we call that a first-degree burn? And then can we say the second was a second, and then third degree would be the dermis, the subcutaneous? Now, National Registry doesn't like to use first and second, third anymore. They like to use superficial, partial thickness, and full thickness. So you better get used to that terminology, okay? So again, if I have a superficial burn, it's what? Superficial. If I have a second degree burn, it's partial thickness. If I have a third degree burn, it's full thickness. You'll probably see that again somewhere. And it kind of talks about the functions of the outer layer of skin. We know that it's dead, hardened cells that just kind of fall off and just kind of regenerates itself. And it also contains some protective pigments as well. The dermis, again, is more elastic connective tissue. And it has a lot of the good stuff, like your nerve endings and blood vessels and sweat glands and things like that. So it's definitely got more hidden goodies there. And then the subcutaneous is, we have the adipose fat, bones, and muscles. There are some institutions, some services that actually use the 4th degree burn classification. And so when you burn down to like muscles and bones, a lot of people will call that a 4th degree burn. Okay? All right. Here again, we like statistics. But if you look at the leading causes of death, this is actually pretty high. It's third among the trauma deaths. So that's a pretty significant percentage. Where do you think most of these come from? Because we really don't pull that many people out of house fires. We really don't. Because most of them are already dead. Okay? So probably we're looking for another source, accidental stuff. Okay? You know, maybe like, what's that? Exactly. That's kind of one I was thinking of. Kids, you know, pouring hot water all over themselves. Kids intentionally been put in a hot bathtub. Okay? So there's multiple sources here. Okay. So if you think about the pathophysiology of skin and what it does, remember we talked about protection and temperature control and fluid retention, all that kind of stuff. So if you take away all that protective stuff, what you're going to have is something like this. You'll have loss of fluid or plasma, which again you said can lead to hypovolemic shock. Now if you were to paint me a picture of shock for this patient, would they be tachycardic? Yep. Would they be tachypnic?
Yes.
Would they be hypovolemic? Yeah. So that is a kind of a normal looking picture of shock, right? And the reason I'm saying this is you guys better get used to, because you're going to see a lot of test questions. They may just give you a small scenario and a set of vital signs and say, what kind of shock are they in? Okay? Now, for example, Bill covered it the other night. If you had a patient that was involved in a car wreck, and they're unresponsive, and they got clear stuff coming out of their ears, and their blood pressure is 160 over 110, and their heart rate is 60, and their respiratory rate is between 10 and 12, what's wrong with them? Negative. I just said they were hypertensive. You don't get hypertensive with neurogenic shock. Did y'all cover head injuries the other day? What does he have? I just freaking told you at the beginning, he's got a head injury. He's got stuff coming out of his ears. He's got a head injury. That's a you're going to see that, so you better not forget that. If you have somebody that's injured and they're hypertensive, shock patients are not hypertensive. Then why the hell are they hypertensive? Because it's not a shock patient. It's what? Isolated head injury. Y'all better get that through your heads, okay? So if you've got somebody that's got hypertension and a slow heart rate and normal respirations, that is a closed head injury. Okay? Please don't forget that. You're going to see that several times. Okay? All right. All right, so burn sources are these that are listed here. Again, chemical, electrical, light, radiation, all of those sources are available to us. So, what do you think is important when you look at a burn? Well, it's right there. Two things: depth. How deep did it burn? Are we talking about a superficial? Are we talking about a full thickness burn? And percentage, okay? And that is what we call BSA. What does BSA stand for? Body surface area, okay? So you need to know that, okay? So you need to know how much of the skin is burned. And as we bury into this lecture, we'll talk about the rule of nines, okay? Because what you want to be able to do is look at a patient and go, you know what? His entire right arm is burned, and his entire back is burned. What percentage of body surface area is burned? Well, if I know that the entire arm is 9, and I know the entire back and lower back is 18, 9 and 18 is what? 27%. So he's got 27% of what? Well, I didn't say. It could be first or second or third, and you have to determine that, right? And how do you determine that? Well, again, as we get into the lecture, you'll see that. All right, so we'll start right here. First degree, again, they like to use superficial, okay? And so if it's a first degree, it involves the outer layer of skin, which is the... You guys know how to figure that out? We know dermis is skin. When you put epi in front of a word, it becomes upon or outside of. That's what that means, right? Like epicardium, it's the sac outside the heart. Remember, epi, upon or outside of. So epidermis.
Dendromus.
What?
Dendromus.
Exactly.
And then the subcutaneous tissue.
Exactly. Okay. So it's red and painful. Why is it painful? We hadn't fried the nerve endings, have we? If we clip the nerve endings, guess what? It's not going to hurt as much. Okay? And tender. It blanches under pressure. This really, most of the time, it doesn't require a lot of anything. Unless you get called to Lake Belton because some drunk guy laid out and his buddies left him out in the sun, and he was out there for 4 hours straight, and he's one big red cherry pile of shit, okay? And you get out there. He's got a 3rd degree burn, and his buddies rolled him over 2 hours within the event. So he's like toast. He's like 80-90% 1st degree burns. Is he sick? What's his bigger problem, though? Yeah, this outer stuff's going to hurt. There you go, dehydration. That's what you're more concerned with. Okay, 2nd degree, again, is a partial thickness burn. And again, it's burned through the outer layer, epidermis, and into the 2nd layer, which is the dermis. And this is kind of what it's going to look like. I'm not going to read that stuff to you. Y'all can read that. But you can see that blisters may be present. Not always. Why is not always going to be there? What do burns have a potential to do? They have a potential to get worse. Okay, burns will get worse with time. Okay, so what may happen is you just got there, and this guy got, he worked on his radiator thing, and it exploded. He got stuff all over him, and he's got some blisters right here. But the other skin around it is just as red. What's probably going to happen to that skin too? It'll develop blisters too. Okay. So 2nd degree burns are, again, not a lot of fun. Are these going to be painful again?
Yes.
Sure. And again, because we hadn't burned down to the nerve ends. So we know that burns and blister are 2nd degree, but not all 2nd degrees don't. 2nd degree burns blister initially. Okay, at time they're going to probably develop the blistering. Can you have 1st and 2nd degree burns?
Yes.
Can you have 1st and 2nd and 3rd degree burns all together? Absolutely. All right, here's our full thickness burn. And so again, this is burned all the way down to wherever it wants to. And so Do you think this guy's in pain or not? Well, it says that third-degree burns aren't painful, but what I want to remind you of is, yeah, I would agree that a lot of this is, you know, third degree, but there's still some skin around it that's what? Not third degree. It's the second degree and the first degree. Are those going to be painful? Yeah, he's going to have some pain. So he needs something to relieve that pain. So do we need ALS Intercept for pain management? Absolutely. What's another reason we need ALS Intercept for on this patient? Why? Why do we need to intubate this guy? Absolutely. That's the answer I'm looking for. He's going to close down his airway structures. When you burn skin, what does it do? It secretes and swells. And that's exactly what it's going to do. So the airway starts secreting and it starts swelling. Okay. By the way, have you heard the word eschar, E-S-C-H-A-R? See this black shading right here? When it's burned that badly, it's called eschar. E-S-C-H-A-R. Okay, now that first statement says that you're not going to be able to tell the level of burn initially. Why? What did we just say a while ago? Yeah, it gets worse with time. Now what can we do to prevent a potential second-degree burn from going to a, or first-degree burn from going into a second-degree burn? Cooling. Okay? You got to cool it. Now what's the fallback with cooling somebody? Yeah, if you're not careful, they can get really cold. So it's okay to cool them for a while, then what do you want to do? Because most of this stuff is you're going to go on with a cooling kind of thing, and then you want to put on a dry dressing. Now it says that infection may convert to a higher degree. So minor burns, because if they got high percentages of them, it may develop into an infection. And it says, when in doubt, overestimate. And I'll kind of give you my side of the overestimate kind of thing. Good friend of mine, one of my fellow captain buddies, he and I were partners for years, and he never got excited about anything. Well, one day I was off duty, he worked his call by himself, and what had happened is this young man lived with his mom, but he lived in a separate shed in the back of the house, and he suffered from mental retardation, but he was functional. And so what he's doing is cleaning our yard, and he raked up a bunch of leaves, and he's going to set them on fire, but then he sprayed them with gasoline. Anyway, it flashed on him, caught his clothing on fire. He was able to put himself out. He was scared because he suffered from mental retardation and went and lay down in his room. The next morning when she got up to get him for breakfast, she said, she called and said, hey, he's burned up. And he had 85% second, third degree burns to his entire body. And so anyway, long story short, my partner picked him up and he called it in, and nobody took him seriously. It's because this guy never gets excited about anything. He says, yeah, this guy's got 85% burn, blah, blah, blah. And they weren't prepared for that. They were just blown away when he showed up. He lived for as long as his body fought the infection, and eventually died. When you have that high percentage of burns, it's a combination of loss of fluid, managing your fluid, and massive infection. Okay, here's a rule of nines, and you need to know this because they're going to give you some questions. Okay, this is a simple way of looking at this, okay? The rule of nines is you kind of take the body, and in multiples of 9, you assign them a number 9. That's what they call it, rule of nines. If you look at the head and neck, and listen guys, when it says head, it says it's talking about the entire head. That's 9%, the front and the back. Like most of these, like the arm, it's 9%. But we're talking about from the socket all the way down to fingertips, front and back, circumferentially. That's 9%. Now some test questions will say, you have a patient that presents with second-degree burns to the front of both arms. How much is that? That's 9, because it's 4.5 for the front of this one and 4.5 for the front of this one. Okay? If it doesn't specify, it's talking about the whole thing. If it says, the question says, your patient has burns to both arms, what does that mean? Not, that means both of them. But if it says specifically front and back or whatever, then you need to consider that, okay? Again, the front of the torso is, and it may say upper chest and abdomen, okay, specifically. But the back is 18, the front is 18, so the whole torso is what? 36, very good. The legs are 18%, and the genitalia is 1%. Now, later on in the lecture, it's going to say that when you get to third-degree burns, you have to have at least 10% third-degree burns for it to become a critical burn. But the exceptions are going to be things like circumferential burns, hands, arms, face, and genitalia. So you can actually have a critical burn at 1%. Why? Because it is a certain body part like we just mentioned. And in this case, it would be the genitalia. Now, you see the numbers kind of changed here. Why? A while ago, the adult's head was what? 9, but the baby's head is 18. Why?
Because the head is bigger.
Because they're all head, absolutely. And so we had to take those numbers away from where? Looks like we robbed them from the legs, didn't we? Okay. And again, the genitalia is still 1%. All right, another way to classify the BSA is what we call the rule of palm. And the size of the patient's palm, that's important. It says the size of the patient's palm. For example, if I had a little kiddo that was burned, and I put my palm, I'm going, well, that is 1%. No. What's a baby's hand? It's about a lot smaller than that, right? So make sure we're kind of considering the size of their palm. So the rule of palm is, their palm is 1% of the BSA, or the body surface area. Again, the other things we want to look at, we've already mentioned depth, and we talked about extent, or the percentage. We also want to look at location. Did we just kind of mention location? Yeah, we said head and face, genitalia, hands, perineum, things like that. Do you think what caused the fire is kind of important?
Yes.
What do you think is more important, if the barbecuer on the weekend that put too much charcoal lighter fluid on the stuff, and you get there and his eyelashes are singed, his mustache is singed, his hair is singed, would you be concerned about him? Or would you be more concerned about the guy that was in a tight room and he's working on a water heater and the room filled up with natural gas, he lit it off and he had a flash fire? Would you be more concerned with him?
Yes.
Why?
Because
It was an enclosed.
Surface area.
What's that now?
It's a chemical.
No.
He's
No.
enclosed.
What?
He's enclosed in an area.
So what?
it affects his
Understand.
body.
How?
And there's more concentration of it. Just
No.
The
No.
gas and the fate and the fume filled his lungs in his face.
Thank you. What happened is, when we pick up somebody from a house fire, what are we concerned about? Well, what we can see, but we're also concerned about, and just a little chemistry, if I set the room temperature is what? 78 degrees. If I set this room on fire, just this room, the temperature is going to change in this room. Okay? So up here it may be upwards up into 1200 degrees. Then over here it's like 600 to 800 degrees. And down there it's like, you know, up to about 300 or 400 degrees. So even at the lowest part, this room is 400 degrees. You ever stick your hand in an oven? Now, do you stick your bare hand in an oven? No, you put on what? A protective mitt. Okay? Now, following that analogy, if you kept your arm in the oven at 400 degrees, what would happen to it? It would burn. And what kind of skin is this? Tough skin, right? Now, what kind of skin or what kind of tissue is inside your respiratory center? Very fragile, right? Okay? Now, would you expose your lungs to a temperature of 400 degrees?
No.
You see where I'm going with this? When you inhale that air that's in that room, it's what? 400 degrees. And so all that you inhaled goes all the way down, and it starts to destroy and it starts to damage and cause trauma to that tissue. Okay, so it's really kind of a simple concept there. Okay. All right. So what caused it? What does the patient age have to do with anything?
The younger they are, the more susceptible
Good.
they are to get hurt.
That's half the answer. What's the other part?
The older
There you go. So the younger and the older they are, they don't do very well, right? And again, the younger is because their immune system is what? Not as developed, and as we get older, it's just worn out. Okay? So that makes sense. And then the associated factors again, was there a trauma? If this guy comes into the ER and you're working on this patient in room 3, doc says, go assess him, and he goes, oh, he's got a lot of burns. Doc says, yeah, but do you know what his burns are from? He ran his car into a tree and exploded. And he's got a tension pneumothorax, he's got some broken arms and things like that. You see where I'm going with this? So he has associated issues that you also have to consider here. All right. Critical burns that require a burn center are third-degree burns that are greater than 10% of their body surface area, and or second degree that's greater than 25%, or only 20% in pediatric patients. Remember we mentioned things like face, feet, hands, and again perineum is the genitalia area, right? And then joints, okay? Now what do you think the hands and the feet are kind of critical, and joints?
Hands and feet are the biggest areas of skin in the body.
Absolutely, and it's very tender. It's debilitating, isn't it? Now, why are joints such an issue?
They keep moving.
What's going to happen in a burn? Skin swells, right? And so if there's no disruption here, and even if there is, what happens to everything below the skin? It gets pressurized because there's a lot of pressure. So there are some cases when the patients are burned badly enough, the doctors intentionally make incisions up their skin called a fasciotomy. Why is that? To relieve the pressure. Because if you don't, what happens? It just starts tearing, okay? And you start having major problems, okay? All right. Airway, respiratory involvement. You're going to hear me say this more than once, but one of the first things I like to do when I get to a victim of a burn, and my burn victims, and I maybe have some involvement here and I'm trying to consider how bad are you, am I going to go ahead and intubate you now? The first thing I want them to do is spit. Why do you want them to spit?
To get all that ash stuff out of their airway.
No, I want to see if the ash stuff is there. You know what I'm saying? If they spit and there's sort of black sputum in there, are you more concerned than just a clear sputum? The reality is, could they have already spit some of that stuff up? Absolutely. So again, that's one of the things I'll look at. If they start having a change in how they sound, if they sound horsey, I'm very concerned about them. And then again, I'll look at the picture too. Was it a confined space burn? How long were they in there? And again, I'll look at how much facial hairs burned and things like that. Other things are associated medical disease, electrical burns. Electrical burns bad?
Yes.
They don't look bad.
It's all
Could be
internal.
from the inside.
Yeah.
Exactly. It's the current that's gone through that's causing problems inside, right? And then again, deep chemical burns. So moderate burns are considered only 2 to 10%, and 15 to 25, and then lower than that in the pediatric patient. And again, minor burns are less than 2% and less than 15%. Okay, remember we mentioned a while ago, the patients don't do well with burns are, and there's the age groups, less than 5 and over 55, okay? And then again, circumferential burns of the chest or extremities. Remember we just kind of mentioned to you, if I had a circumferential burn around my arm, it would cause a lot of pressure. Okay, could it cause a lot of pressure if I have burns around my entire torso?
Yes.
And again, that really affects breathing. All right, let's talk about some management stuff. First thing you want to do, within reason, if it's within your ability, and again, we always want to make sure the scene is safe. What we're not promoting is you guys show up to a house fire, you're rolling on a call with me, you guys decide to go in. We have our police officers do that crap all the time. And I'll tell them too that sometimes they make life a lot more difficult for us because they go around a structure, and it's not just about when I go up to a house fire, it's not, hey, put the wet stuff on the red stuff. It's kind of a science now. We look at our plan of attack. We look at how much water it takes to put it out, where our injection points are and things like that. Sometimes cops go in there and they start breaking out every window. And so, you know, they can make things very difficult for us. So the best thing for them to do is just kind of control traffic. But, you know, I'll tell them. They're good friends of mine. But anyway, the first thing you want to do is to move the patient from the source of injury if possible. It says remove clothing unless it's stuck to the burn. Kind of like that. If it's stuck to the burn, what are you going to do? Cut the rest of the clothing away, like the zipper kind of thing, right? So that's kind of what you want to do there. Obviously, you want to assess the big things like the airway. And it says to give oxygen if a moderate or critical burn, and if any of the other conditions exist. You know, signs of respiratory involvement. How do we know they've got respiratory involvement? I just told you, black sputum when they spit it out. Nasal hairs that are burned. Reddening on the inside of their mouth. Okay? Is there a history of CO or smoke exposure? And we're talking about CO is not carbon dioxide, it is carbon monoxide. And we have products of carbon monoxide in a house fire. Absolutely. So what's so bad about that crap? Well, it changes the what? The makeup of oxygen that's available for patients. Okay? And go ahead and assist ventilations as needed as well. All right. So if you have a patient that is shocky, they present shocky in the incipient stages, then you should consider they got additional injuries, not just that. All right, so other things you want to find out are how long ago. You generally think that when we go to fires, it just happened. A good example of it did just happen is what I told you ago by my friend. What do you think they could do before you get there? Do you think people might put some home remedies on burns? Mm-hmm. And what are some of the home remedies? What's that?
Chewing tobacco.
Really? Chewing tobacco, there's butter, petroleum products. There's all kinds of junk they put on there. Grandma used to tell, I think we've kind of phased most of the grandmas out of this equation, but they'd put butter on those burns. Oh yeah, baby, you're going to be all right. Just put a little butter on it.
And butter makes it worse.
Anyway. So what caused the burn? Again, the closed space. Was there a loss of consciousness? Is there any medications and or allergies that we need to be concerned with? And any past medical history? Remember to check for other injuries. Rapidly estimate, their body surface area, and is it important to remove constricting clothing? I mean stuff like watches and rings and stuff like that. Yeah, we don't think about that kind of stuff, but it needs to come off real fast. You're going to have that man that says, I never take my wedding ring off. My wife told me never to take it off. Okay, that's fine. Your wife also tells you can lose that finger. So it makes it a lot harder to cut a ring off once your hand starts swelling. But we actually have ring cutters. It used to be the end-all, save-all, but they're not as good anymore because there's a lot of rings out that are made out of, special materials that are very difficult to cut. But I will tell you that most EMS services and fire departments carry what's called a ring cutter. It's kind of a neat thing. A can opener, how that works. Same thing, except on this, one of the bills is a little hook that slides underneath the ring, and the other one is that little knob that you rotate like this. It's got a little serrated wheel, and you clamp down on this, and as you turn this like a can opener, you're squeezing this, and you're cutting a little bit more every time. Now, if you cut a ring off, I've talked to a number of different jewelers, and they say don't cut it in one singular spot. because what's going to happen then is I got to spread the ring, and it's difficult to get it right back around for them. So the better thing to do is just cut a section out of the ring, and they can make it just as strong. Okay, so up to you, whatever your system wants you to do. All right, cover with dry, clean sheets. That must be a test question because it's bolded. Okay. Can we go ahead and put wet stuff on it to cool it first? We mentioned that a while ago, didn't we? And don't be popping blisters. And whatever you do, don't put oil-based products on the burn. This is a good stopping point. Let's take a break. I didn't eat, so I thought this place over here had a Subway. Huh?
Nope, that's all over there.
Over where?
Over by, what is that, Central? And 31st, around that area?
Central. Oh, yeah.
By ATV. That's the only Subway.
Yeah, it's between Central and Adams on...
Whatever that street is.
Mhm.
If that's 31st, I'm thinking it's probably like 30 or 28.
No, what's interesting about the city... Let me turn this off. You gonna learn something here.
I do.
Okay. Anyway, sock-like pattern is like if you have a kid and then they look like they're wearing two pink socks because somebody has taken them and dunked them into a bathtub of hot water, okay, or their buttocks are just cherry red, and then the parent may say, well, the kid got in the water and the water was too hot. Well, the way I look at it is that wall in that bathtub is about that high, right? And the kid's probably going to go one leg at a time, and when the second he feels that that's too hot, what's he going to do? He's probably going to pull back. So unless the kid can do like a 14-inch vertical leap, that story don't fly. So you got to look at what they're telling you to make sure that the pattern of injury matches the story they're telling you. And sometimes it just doesn't, okay?
Do you come across those so much?
Of abuse? Sure. Okay, remember we talked about their immune system was limited. The small airways are limited too. And kind of the way I like to remind people is if this illustrates the normal diameter of a pediatric airway, and this illustrates the diameter of your airway, if I gave each one of these 1 millimeter swelling, does that make much difference here? If I reduce that by 1 millimeter, does that make a lot of difference there? Absolutely. So remember, their airways are a lot smaller, a lot more sensitive, plus their immunity systems can't fight for them very long. Their lung compliance is not as good, so they're not gonna deal with that very well. And geriatrics, they have thin skin, poor circulation, and they always generally have a lot of underlying diseases like pulmonary, peripheral vascular, things like that. Their heart's not working as well. And again, their immune systems are decreased as well. So the percent of mortality equals the age times or plus the BSA burn. So you always look at those two factors. How much was burned and how old are you? Okay, in geriatrics. All right, when you look at this, again, your concerns are if his eyebrows are singed, his nose hairs are burned off, and then, yeah, that's all the superficial stuff. The face did what it's supposed to, it protected him. What we're hoping, though, is what? That and he didn't inhale whatever that was. Okay, absolutely. And the likelihood is that he probably did. Okay? So the problems associated with those are you can have hypoxia because there's dissociation between oxygen and their environment. Again, that has to do with that leads into carbon monoxide. Carbon monoxide has a higher affinity for hemoglobin than oxygen does, so it binds to hemoglobin and you don't get a good transfer of oxygen. Upper airway burns and lower airway burns, which would you rather have?
Neither.
Lower.
Neither? Good. I wouldn't want lower. Why? That's where all the good stuff happens. That's where air exchanges, absolutely. But you're right, neither one of them are any good. But again, the way I look at it, if I have upper airway burns, I'm really, really kind of hoping that it didn't go all the way. I just kind of took a small, and I stopped right there and held my breath, ran out of the room. Can it happen? Maybe. Don't know. I just thought about that. There was a kid that I knew. His mom went to my class. His house caught on fire, and I interviewed him afterwards, and he said that he was babysitting, and his house caught on fire, and family went in two directions, and some of them got out, and apparently he went back in the house for his little brother who just got out of the shower or something like that. And he got him, and he said, okay, start running that way. He was kind of directing. And so he saved his little brother, but he said about halfway through the house, he fell down. And this is I believe in God. I know I have a foul mouth and I'm working on that. But he actually said he fell down and a power picked him up. He said it's like lifting hands picked him up, because he didn't pick himself up and was able to find his way out of that house. So anyway, what is carbon monoxide? It is a product of incomplete combustion, fossil fuel products. So it's the off-gassing, okay? It's that, what is it that gets people in trouble in the house? Anybody know? Where's carbon monoxide come from? Well, the good sources, like the stuff that your, what do you call that? The thing that heats your home? Yeah, no, the central heat and air system, okay? It has, when it starts burning that gas, what's it pushing out? The gas products, right? It's the smoke and stuff like that. A lot of times what happens is those ducting systems, they kind of get off at the time, and they get off or they get a hole or whatever. And so what are they dumping inside the home? Carbon monoxide, okay? If your gas-fired appliances aren't working properly, if your fireplace is not venting properly, all those things can lead to what we call a sick home. Sick home is when we get a lot of calls a lot of times that people go, you know what, I put a carbon monoxide detector and that thing's going off. So we come in with our little gauges and meters and we started reading percentage of carbon monoxide in the home. And a sick house is when people come into the house and they got a small leak, which means they've got acceptable levels of carbon monoxide, just enough to make them feel really crappy. And the way you feel with carbon monoxide poisoning is you have flu-like symptoms. Looks just like the flu, okay? Minus the ringing in the ears. But anyway, or the roaring in the ears rather. But they have headache, nausea, vomiting. When they get out of the home, they didn't have a fever with it. When they get out of the home, go to work, they go, I feel fine. I just feel like crap every time I go home. So if you're one of these people and you feel like crap when you go home, you might want to have your house checked. I tell people that because they just don't understand that, it's really important. All right, so I think we talked about, when we talked about the pulse oximeter, we said one of the things that is really not helpful is reading a pulse oximetry device in the presence of a suspected carbon monoxide poisoning. What you're going to do is get a false reading. You're going to get a high normal reading, and somebody could be suffering from carbon monoxide poisoning. Now, the indicators somebody's got carbon monoxide poisoning, I think the test question is they have cherry red skin color. But is that an early indicator or a late indicator? Or do you know, or are you just guessing? You're guessing. Sack of shit. You're right. Good guess. But you're right. It's a very, very late sign. All right. We kind of shifted gears and we're talking about upper airway burns. These are the true thermal burns. the things that we look at, and I mentioned some of these, and there it is, hoarseness. The ones that kind of really get my attention, get my hair standing up, is I listen to them talk and they spit up black stuff. I'm going, well, is there anybody you want me to call for you? Any important people you want me to call for you? Because you're going to be unresponsive here for long because we're going to put a tube in you. Okay? So, and I don't wait. You don't wait on people like this. You don't wait till we get them in a perfect environment. We're going to probably sedate them, put them down, and start breathing for them. Okay? Now, why the drooling? Why do they have drooling?
Maybe because of the swelling. They can't really like swallow.
It hurts to swallow, absolutely. All right, lower airway burns. Again, some of the things you look for are their loss of consciousness with a closed space. They have tachypnea that's gone into a decreased respiratory rate, the coughing, ralls, wheezing, bronchi. What are ralls and bronchi? We know what wheezing is, don't we? Mm-hmm. So ralls and bronchi must be what? Some kind of abnormal respiratory breathing sound, okay? A lot of people, including myself, when people have funny sounding lungs, I use the word adventitious. It's kind of an all-encompassing word, adventitious. In other words, they say their breath sounded funny. And sometimes you can just say they sounded coarse or they sounded like wet or rubbing. There's going to be all kinds of descriptors out there that we use. Okay? And then what is carbonaceous sputum? What I told you about. Spit. See what that stuff looks like. All right, so when you're dealing with chemical burns, again, that's it begins externally, and even though that looks bad, what is a greater concern? Yeah, that stuff absorbed through the the layers of skin, and that toxic effect may be causing more problems for your patient than just the superficial stuff that we see. Important things are that you guys don't get cross-contaminated, meaning that in the process of getting them washed off or irrigated, you get some of that stuff on you. All right, so management, you should remove the chemical from the skin. And I think these are test questions. If it's a liquid-based product, you can flush with water. And usually it's a lot of water. We say copious amounts of water. Now, dry chemical, I know that is a test question. And what you want to do there, you think he had my number?
Mm-hmm. You put it on the board.
Let me make sure it's, hello?
Hey, Captain Morgan, this is Nick.
Hey, man.
Hey, I was just wanted to say you got to go ahead and start. I'm on my way back. It'll be just a sec. And then we'll try to
Okay.
wait on me.
Okay, thanks. Bye.
All right. Great.
Bye. All right. For dry chemicals, you want to brush them away, flush what remains with water. Now, I'm going to tell you, this is what we're looking for the test. But as a hazmat technician, we don't brush crap away. Why? Because now I've got these little filtrates moving up, and I aerosolize this crap, and it becomes airborne. Okay? So the better thing for me is I cut your clothing off and just open it like a sandwich very gently. Okay? And I put it in bags and stuff like that. But I just don't like fluffing in because, again, I just get all that stuff everywhere. But for you guys, for the test question, this is the answer you're looking for. Brush that stuff away, okay? And then flush with copious amounts of water. When we decon people, we find that just by removing their clothing, we've probably taken away about 80% of the contaminant from them. So, is it important to remove clothing? Sure, I think so.
To take everything off?
I might leave their lizard skins on, but the rest of it's coming off. Their chonies. Okay? Their underwear.
What about if it's a female? They have bra underwear.
That's what you get. The rest of it comes off. And yeah, we leave that on. Now, we actually, we have secondary clothing for people that we decon. The thing is, you know, I know modesty and all that kind of stuff, but the reality is the ER won't accept you if you're not deconned. They will refuse to let you in their facility. It makes sense. I don't want a dirty patient in my hospital, because what does it do to the hospital? No, yeah. Nasty, dirty patients have been the death of some hospitals. Absolutely. All right, with phenol, and listen, I know you guys are going to remember this slide, and that's fine, but most of your test questions are going to be directed to, if you've got stuff on you, what's the best way to get it off? With copious amounts of water. Okay? And I know you guys are going to say, well, let's ask for phenol. We need to flush without. That's fine. But none of your test questions are going to ask you that. It's just going to want you to know, get the stuff off with copious amounts of water. What's that? All right. Now, tar. Thank you, sir. You can use cold packs to solidify the tar, and at that point, it's kind of like a special process to get that off. It's kind of like dipping your ice cream cone into a vat of chocolate. That's what you're trying to do. And let somebody else take that off. They can use organic solvents to remove that stuff. Again, chemical in the eyes. You can flush, and we told you that NS and ringers are just nothing more than IV solutions, and you shouldn't be introducing any other chemicals into the eye. Has anybody ever used one of these eye stations? I've got one of these in my stall, where my apparatus room is, and periodically I'll hit that thing. When I hit it, nothing but rusty water comes out. So you might want to make sure that that's flushing clean water before you start washing somebody's eyes. All right, electrical burns. Looks like the kid at the bottom's bit through some kind of hot wire extension cord or something like this. Some pretty significant burns up on top, and this is definitely, looks like a power line made contact with the skin. And again, as gross as that looks, as bad as that looks, that's just kind of like what we call the tip of the iceberg. There's a lot more stuff that kind of went through the body. So considerations with electrical burns are, you know, the intensity of the current, how long were they attached to that current. Okay, most people with high voltage electricity, if they're lucky, they hit it and they get knocked off. The problem is that, you know, when your hand or body contracts around a wire, it causes those muscles to spasm, and then you can't get off of it. Okay, the kind of current you're dealing with, whether it's AC or DC, and then types of tissues exposed, which is nothing more than resistance. We mentioned this. We said that the conductive injuries, what you see, you know, somebody could have been holding an aluminum pole and they were in a bucket, and when you get there, they got just a burn, looks like right here in the hand. But then you take their shoe off and their toes are blown out. So this is not bad, and the toes are a little worse than the hand, but guess what? And what did the electricity do? It's lazy like anything else, and they just follow in the path of least resistance. So it could go through a lung, you know, major organ, stuff like that. So, and again, it doesn't list it, and I'm surprised it doesn't, but people that have electrical burns are more susceptible to developing what? Does anybody know? Arrhythmias and going into ventricular fibrillation. So when I have people that, like your common, I work on air conditioning all my life, and yeah, I've probably been shocked 3 or 4 times kind of thing, and just another day at the office, okay. I had a kid the other day that was shocked. And same kind of thing. And I said, well, you might develop rhabdo. He goes, what? I said, well, when the electricity went through you, it started breaking down fat. And this high fat content is going to go straight to your what? To your kidneys. And it's going to cause your kidneys to do what? To fail and shut down. So you want to go on renal failure? No. So what we need to do is give them a lot of IV fluids to get them to do what? There you go. So paint an ugly ass picture for them if they don't want to go with you. You might die. You could die. You should be dead. Why ain't you dead? Again, looks like the guy grabbed the wire there, and you can see that ground was the lower part of his body in this case, and he had kind of a blowout injury right there. So again, those are just the things that we see and go, ooh, that's bad. Well, yeah, he may lose a foot out of the deal, but I'm willing to bet there's a lot of tissue destruction inside too. Okay, so some of the other problems, you could develop cardiac arrest and arrhythmias, stop breathing, obviously have fractures as well. Okay, so management strategy should be to turn or make sure the current is turned off. Now, when you go to an industrial type accident, you know, most of the industrial settings, they have what's called a lockout tag-out system. And so when their maintenance folks, electricians, go work on a piece of electrical equipment, they are by OSHA regulations required to lock out, tag out that system. So the power source that drives this conveyor belt, for example, they go over there, they get a work permit for it, they got their locks on here, and they lock this thing out so that somebody can't accidentally go, I need to turn this thing on because somebody accidentally turned it off. Can you imagine turning something on when somebody's working on it? Okay. And then what we have is we have our own lockout tagout system. So we come over here, they got theirs locked, we put a little lock on top of their lock. Now you don't turn that on until we, the fire department, are through taking care of your emergency. Right? Alright, so make sure the juice is turned off. So are plant personnel going to be vitally important to you? Yes, they know their equipment. They know how to turn it off. And you just, the other thing you just don't do is just start arbitrarily turning breakers off. Because you could fry a grid system in an industrial setting. So you may have to do it in stages. You don't just go turning crap off. Okay? Again, assess carefully for other injuries, and you need to encourage them to go. All right, good deal.
I'll give you another one. Some of the pumps and stuff we have at the water plant, you can't just flip a switch. We actually have to take an oil vat out of the wall, out of our cabinets.
You have to do what now?
We have to take an oil vat out of the cabinet to kill the circuit.
Really?
Yeah. That old.
Huh.
And then there's some that's just a big copper cage or copper block brick. We've got to yank it out.
Yeah.
Otherwise, the current can still go through.
Yep. A lot of specifics. You know, we rely on the people that work in the industry to tell us this is okay, this is not okay, things like that. All right. This section is trauma and pregnancy. Pregnant women are going to be involved in car wrecks. They're going to get the hell beat out of them. They're going to get kicked in the stomach. They're going to fall, things like that. Okay? Trauma, again, is the leading cause of death during pregnancy. It says the car wrecks cause 50% of the prenatal mortality. So what we're saying is these kids are dying because mom's injured. And if I could just stop there for just a second. You see this little baby's house right here? What is that baby's house? That's the uterus. That's his house. Okay? Now attached to that house is what? from the baby to the umbilical cord, there's a disc that attaches to the uterus called the placenta. Okay? And then the umbilical network goes to the baby. In a non-pregnant state, women will send 2% of their blood flow to their uterus. Okay? When she becomes pregnant, that number goes from 2% to 20%. So that number really increases, doesn't it? Why? Exactly, because now we know that a placenta is going to attach to that uterine wall, which is going to go to umbilical cord, so it's going to go to the fetus and feed and develop the baby. So it takes a higher percentage of blood away from the mom. That makes sense? But that's okay, because what mom's going to do is, through her pregnancy, she's probably going to add about, if she has like 6 liters of blood before she got pregnant, she'll add 50% of that. So she'll add another 3 liters of blood volume to her body. Why? Because she knows she's feeding baby. But here's the kicker. Of that 3 additional liters she put on, not all that is the same nutritional value. It doesn't have the level of red blood cells and white blood cells and stuff like that. So it's not the same. So what's kind of cool is, and not really cool, let's say mom, she's in her 3rd trimester of pregnancy. She's got 9 liters of blood now, and she's sending 20% of her blood volume to the kiddo, right? But mom's got this biological switch in her, and it's self-preservation. So let's say mom's in a car wreck, she's got a chest wall injury. The body senses, hey, we have blood loss, we have chest wall injury, so we're going to go back to what percentage to our uterus?
2.
Exactly. So you think that's going to hurt the baby? Yes. That baby was used to what?
20.
And he's getting what now?
2.
Do you see why babies die? They get in trouble real quick. So what do we need to do? So is it safe to say that whatever we give mom is going to be good for the baby? And whatever we don't do for mom is going to be bad for baby too? Mm-hmm. Absolutely. What are childbearing ages? 12 to about 50 or something like that, 55, whatever. That's kind of the norm.
12.
What's that?
12.
You bet.
Once they get their period, they can get pregnant.
Holy crap.
I can actually be on up to 11 years old now. So.
Yeah. Okay. So what we want you to understand in trauma and pregnancy, you really don't want to change or alter anything, do you? Trauma's trauma. ABCs are ABCs. Initial assessment's the same. We're not going to change that stuff. We're going to do exactly what we used to do. We have to realize what now? We got 2 people we're trying to take care of here. Okay? So I think what we just kind of made these statements a while ago. Mom dies, baby's dang sure going to die. Okay? And if you do something good for mom, it's probably good for the baby. All right. Now let's talk about these for a second. It says as a pregnancy progresses, so we're talking about, and in pregnancies it's broken up in 3-month sections, and they're called trimesters, okay? So you have the 1st and 2nd and 3rd trimester, okay? So as she gets deeper into her trimesters, things start to become more obvious. But what starts to happen is the heart rate increases. Why? She's got more blood to pump, right? And she's supporting blood flow to the baby, okay? It says the blood pressure decreases. Why? There's more volume. Remember we said there's 3 additional liters here? Absolutely, okay? So if you look at those two, just those 2 vital signs, a normal mom looks what? Yeah, she looks like she's hypotensive or hypoperfusing. Okay, that's kind of normal for her. So you show up to a car wreck, mom's got, oh, my belly's bleeding, I've got vaginal bleeding, My belly's hurting, I got vaginal bleeding, I don't feel well, and she's shocky looking, and you take her vital signs, you're going, uh-oh, her heart's already increased, her blood pressure decreased, but that's supposed to be normal. Common sense is going to tell us what? You're hurt. I know that. You're telling me you're hurt. I don't need to look at vital signs. I don't need to get confused. When we talked about this lecture, that what are your vital signs supposed to look at? Sometimes you just got to use gut instinct. Okay? Remember we said blood volume increases by up to 50%? That's what's interesting about it, is of that, they can lose 30% of that before they start to developing signs and symptoms of shock. Now let me ask you this. Do you think that a pregnant mother may know what her vital signs are during her pregnancy?
Yeah.
Probably. Better than anybody else. Why? If she's getting prenatal care, the doctor's actually monitoring her weight gain very carefully, is he not?
Yes.
And he's telling her, if you get, because one of the things moms don't want to develop is something called preeclampsia, right? Preeclampsia is a condition where they get very hypertensive, they start swelling a lot and retaining fluid. And they kind of manage that by, you know what, you're only supposed to gain a pound a week. Now you gained about 4 pounds this past week. That's not good. We're going to have problems with you, okay? And again, reversal of hypoperfusion is more difficult. Y'all understand that first statement? Is that kind of like what I just told you a while ago? That's what it's trying to tell you. It says blood flow to the uterus, placenta can be selectively reduced. Remember? That 2% to 20% kind of rule. Okay. So baby gets in trouble. What do you think at a minimum that baby's going to do? In other words, that baby was he was living large, he was gaining 2 pounds a week, things were going great, mommy's feeding me, blah, blah, blah. And all of a sudden, mommy's in a car wreck. I don't know what's going on. I'm just a little infant trying to develop, trying to get through this thing. Okay? So all of a sudden, the kid gets shocking. He doesn't know what's going on. He's getting less blood flow. So what do you think he might do?
Start showing.
He may go, hell with it, and I'm going to take a crap. It sounds funny, but babies will actually take a stool in their sack. And the reason I'm telling you this is because what happens sometimes when babies are born, there's this greenish, pea, soupy looking stuff on their face. It's called meconium stains. And what's meconium stains? I just told you, that's poop. Absolutely. Why did he poop to begin with? Because he got distressed. Because why? Mom was in a wreck. She fell. Something happened. Okay, this is kind of cool. We may have already talked about this. I'm sure we have. It's called. Anybody tell me what this is called, by the way? I think I told you it a long time ago.
Oh, okay.
And then let me just kind of walk you through it. Okay. Remember when mom, a regular non-pregnant woman, she lays flat, she's okay. She doesn't have, 15-pound bowling balls sitting in her belly, right? Mm-hmm. Now, when pregnant mom does that, she's laying flat, and what is behind in kind of the medial part here? She's got an aorta, and she's a descending aorta, and she's also got what? Inferior vena cava. One's a high pressure, one's a low pressure. So this baby's going to do what?
Sit on it.
It's going to squeeze on both of them, but is it going to affect the aorta? Is it going to affect the low pressure vessel, the inferior vena cava? And so that reduces blood flow to what? To the heart, which can be pumped to the rest of the body. That's exactly what it does. Okay? And that is called what? What position is mom when she lays flat?
Supine.
Thank you. That's the first word. And what's low blood pressure called? Hypotensive. And so it's supine hypotensive syndrome. That's what that condition is called. So when you hear us use that supine hypotensive syndrome, again, that's exactly what happened. So what position should you transport mommy in her third trimester? Which side, right or left, or does it matter?
Left, right.
I got it right and I got it left. Always the left. Why the left?
release the pressure from the
because the inferior vena cava is slightly to the right of the aorta. So if I lay them on this side, guess what? I'm still putting the pressure on that. So yeah, you want to put them on their left lateral recumbent side. Now, can I put them 100% on their left lateral? Or what happens today if mommy happens to be in a car wreck and I put her on a backboard, the C-collar and all that crap? Can I tilt the backboard and all that crap? Yes, I can. Sure can. And most mommies, when they get into the third trimester, are you going to get them to lay on their back anyway?
No.
You ain't going to happen. Okay, so again, the management things, the things that we know. Remember, take care of their needs, resuscitate them, and realize that if mommy's injured, mommy's falling down a flight of stairs, is there a good possibility there's injury to the baby?
Yes.
Yes.
You bet. And that's what she looks like in a tilted backboard kind of thing. Is that scary for her? Yes, it is. It's real scary for her. And the dangerous part of this is you have to be extra careful when you're moving a stretcher like that, because now the stretcher is not on center. It's actually loaded on the left side. So if I'm going sideways with that stretcher, which you should never do, and I hit any imperfection on the ground, you bet. So when I have mommy like that, I don't like to use 2 rescuers. I want 4 rescuers on there. I want 2 bodies on each side. That way we can compensate for anything that might happen. All right. No, it's pediatric. This used to be one of those lectures where we got out early, but I think he's really... Oh, we might be able to get out early. Have y'all ever been out early yet? I've not let y'all out early, have I?
No.
Well, the day we took the test.
You're 15 minutes in. You call that early?
Huh?
We took the test.
Toward the end of this thing, you'll be getting out early. You'll be going, oh, that sucker's already let us out. Okay. Pediatric trauma. Trauma is the #1 killer after the neonate period. And again, are kids little adults?
Yes.
No, they're not. They actually talk about that. Be careful, because a lot of people say kids are little adults. If that were the case, if I have a puncture wound to an adult and a puncture wound to a kid, are they going to bleed the same rate? Yeah, they will. But if I've only got a Coke can full of blood as a baby and I've got like 6 liters as an adult, is there a big disparity there? Yes, there is, okay? So don't treat them as they were just a little adult. I mean, yeah, they kind of look, we all want to, oh, you look like me, you look just like me when you grow up. Why? Why do I want to look like you when I grow up? Sad. Anyway. Okay, there it is. ABCs, make sure you're managing the ABCs. All right, this is why we say they're not just little adults. Yeah, they've got a tongue and hyoid bone and all that kind of stuff. But anatomically, these are some of the things that actually change. Would you all agree that kids' heads are much larger? Yes. The other day, remember when we were doing the spinal stuff and we said if you have a kid, should you change something before you put them on a backboard? We said yes, you want to put some padding behind their shoulders, and the reason is why? You want to bring the spine in alignment with the head and neck, right? So again, large heads, short necks, small mandibles, their tongues large, and it sits back farther. The roof of the mouth is much lower. Remember, when we put in an oral airway, we don't do what?
Twist.
We don't twist it. That's why, because the roof of the mouth is much lower. And friends, this is what scares me probably more than anything about a kid. And there was a case yesterday where one of our officers helped a kid that was choking on a hair barrette or something like that. If I wanted to do a surgical crike, on you. I would do a surgical cric on you because you have an airway obstruction that I can't fix. Okay? Your surgical airway, your obstruction, the lowest part of your airway or smallest part of your airway is above what I call the cricothyroid membrane, the Adam's apple. The smallest part of a kid airway is where? You see that area right there? Is right here. And that's where you start getting into the tracheal rings. I cannot do a cric in the trachea. If I cut the trachea wrong, it collapses like a coiled spring. So this is where I'm supposed to do a cric right here. So again, a kid swallows a marble, what happens? I can't do anything for him. Okay? There's nothing I have that I can do for him. Okay? Let me just share this with you while we're talking about this on the lighter side. There's some guys shooting pool. It's not a joke. It's actually a real case. Shooting pool. And guys shooting pool are always... Thank you. Okay? And so one of the numbnuts goes, I think take this cue ball and I bet I can swallow it and put it in the back of my throat. And what do you think happened? He did. He took that big ass cue ball, put it in his mouth, and it lodged in the hypopharynx right here in the back of his airway. Now, remember when you have somebody that's got an obstructed airway, what do? The Heimlich maneuver. Are you going to be able to generate enough pressure to pop that heavy ass ball out of his airway?
No.
And what had happened is when EMS got there, his whole inside of his mouth was just it was shredded. His buddies were running their nails, so they're trying to pull it out, and every time they hit it, what would it do? It rolled, it got slick, it got bloody, and he pretty much just died in front of them. Horrible way to die. Of course, when we were going over this case, it was one of my hardcore Vietnam buddies. He said, he kind of listened, he goes, well, why didn't somebody just take the cue stick up his ass and knock it out the other way? Well, that might have worked. But the guy died miserably. Okay. My point, though, is once you get certain area, you're not going to be able to be very effective with them. Okay, this is a perfect example. Remember we talked about kiddos? They got that huge head, and if they go unresponsive, their head does that hyperflexion kind of thing, and their airway is totally closed. So if I want to get that chest and that neck and that head all in alignment and also line that spine up, the best way to do it is provide scapular padding behind the scapulas, okay? And that works pretty well. Okay? Remember, you can do these things to make sure the airway's clear. You can use, I tell you one thing I don't use, and did you guys remember when we did the nasal airways? Mm-hmm. Do you remember when we did the oral airways? You saw some little oral airways, didn't you? Mm-hmm. Yeah. Did you see any little nasal airways? No. What does that mean?
You don't put a nasal
We
airway.
probably don't use nasal airways in kiddos. Okay? All right, these are some other things that happen. There are smaller passages obstruct easily. We kind of made that illustration a while ago. They have poor respiratory reserve. And it says swallow air may limit ventilation. What does that mean? Swallowed air. When kids are hurt, what do? They cry. And when they cry, what do? They're sucking air, aren't they? And it goes where? Into the esophagus and into the stomach and does what? Exactly. So they're going to throw up eventually, but what's the other thing they do? The stomach's filling up, and what's just above the stomach?
Or diaphragm.
Thank you. And so what does the diaphragm do? The dome of that diaphragm comes up, just like a dome. And it's increasing or decreasing the lung volume size? Decreasing. Very good. So you need to be looking at these kiddos and determine whether or not they need to be ventilated. Is fast breathing acceptable in a kiddo? Yeah, they breathe faster than we do, don't they? Now, what are you concerned when you see a kid breathing fast? What are some of the things that concern you? You should be able to spit some stuff out. Like, if they're
Hypoxic.
bring it.
using more muscles.
Okay, accessory muscles, good. What else? Hypoxic, what else? Pulse oximetry bad, what else? Wheezing, what else? Don't look good, what else? Delayed capillary refill, very good. So if you see that stuff, you should be concerned, okay? What is that last bullet says? It says auscultation of chest may be misleading. It's transmitted breath sounds. I think I may have told you at the very beginning what that means. When I showed you to listen to breath sounds, where did I tell you to listen first? Mid-axillary. Okay? I did that for a reason. Now you take a baby's chest about that big, okay? And if you listen, you get in the habit of listening here. What's the space between those 2 points? There's none. There's no space there. So you listen to the right and then you listen to the left and you think, I'm hearing sounds on both sides, but what are you really hearing? A transmission of breath sounds from right to left. But if you listen mid-axillary, there's a pretty good distance even in the kiddo, right? So I want to make sure what air is getting to the lower bases, the lower lobes there, okay? So don't let the transmitted breath sounds fool you. Again, they're obviously have a much higher metabolic rate. They're more tachyptic, more tachycardic. They have a lower reserve capacity, and combine that. So, and they don't do well with airway issues and respiratory issues. So, how do you know a kid's hypoxic? You should be able to answer this without even looking at your notes. What does their heart do? Thank you. Huh?
Get tired.
Negative. Thank you very much. Remember, you and I, our heart rates do what? They shoot up. Kiddos, when they get hypoxic, their heart rates do what? They take a nosedive. So remember when we talked about when you suction a kiddo or anybody, how do you know you suction too long? I think I told you they get bradypneic. Their respiratory rate slows down, and their heart rate drops. And when their heart rate drops, what are you going to do? Don't give them meds, and or oxygenate them. Thank you. All right. Is controlling the bleeding important?
Yes.
Why?
Because I don't have a lot of blood.
Do they have as much blood as you or I? Not even close. Okay. So combine that with the fact that second bullet says that kids have excellent compensatory mechanisms. What does that mean? No. They're going to compensate for shock a lot better. Why?
They're
Smaller, they can react faster.
Okay.
The body's more automatic. The automatic nervous system is much quicker in a child.
Okay. This is kind of a way I look at it, if it makes any sense to y'all. And most of the crap I tell you doesn't make any sense, but it's okay. You take a kid, and he comes off the assembly line, and you take a 50-year-old man, he comes off the assembly line. But the problem is this guy, with his 51 years old, has been doing what to his body? Abusing it, and what else? He's been eating whatever he wants to eat, and what do you think he's done to his heart? Do you think he's weakened his heart? What do you think he's done to the diameters of blood vessels? Do you think they become smaller because of the crap he's eating? Now the little kid comes off the assembly line, what does he have? Brand new heart, very strong pump, and what's the deal with his blood vessels? Probably very clean, right? So you think he's going to compensate really well for shock? He has to, because his system is brand new, it's working well, it's working the way it's supposed to, okay? So they compensate extremely well. The problem is, and I think you've probably heard this, right? Remember we talked about us and our stages of shock, we kind of go up, and then we take a gradual slope, and we take that roller coaster ride gradually comes down. What do kids do? They spike, they get to the top right here, and they drop. There is no gradual, I'm going to go and I'm letting you know I'm going in from compensated to decompensated to irreversible shock. Are you paying attention? What do? They peak and drop. So you got to be careful with them. Okay, yeah, I don't like taking blood pressures in kiddos. It's difficult, and it's just not going to give me the value and the powerful punch I'm looking for. Okay, so some of the other things we're going to be looking at are peripheral pulses. When did we tell you that capillary refill is best used in what population? There you go. Okay. Skin temperature and color. Remember, look at their level of consciousness and their quietness. Who is the best indicator, or what is the best indicator that the kid's just not right? Their parents. If mommy and daddy say something's not right, I can't put my finger on it, then guess what? Something's wrong, okay? Okay, do you think this is going to be a real emotional event for that kid, getting separated from mom? Absolutely. They're hurt. They don't know what's going on. And depending on the age group, they all really respond much differently. Like a 1-year-old, yeah, I'm yours. Whatever you want to do, I'm cool with that. When you get to a 6 or 8-year-old, they're concerned about modesty and disfigurement and all that kind of stuff. They've no pain. They've seen kids that are crippled. They've seen them in wheelchairs. They know all this stuff. So, yeah, it's a huge emotional impact on those little guys. Okay, head trauma. Again, it is the leading indicator or cause of death for kids because, again, they got big heads, thin skulls, and again, they don't have a whole lot of strapping muscles around their neck, do they? So their little head's just going to do whatever it wants to. It's like having a big-ass bowling ball on top of your shoulders, and it's kind of controlling me. It's kind of the head goes and the body follows kind of thing, okay? Okay, so monitor for signs of increased ICP, and ICP when they did the lecture is what? Intracranial pressure. Thank you. Is that something that's important to us? Yeah, absolutely. So the things we're going to, let me ask you this, is a kid going to have the same ability to tell you I'm sick as an adult?
No.
Do they have the same verbiage and grammar skills?
No.
So absolutely not. So we're going to have to rely more on things like their crude things like are they alert and things like that. Their pupils. Are they vomiting? Is vomiting an important thing? When I look at vomiting, I look at, is this regular vomiting or is this projectile vomiting? Because when I see head injury, the first thing that pops into my head is Linda Blair and what is that? The Exorcist. When they start the projectile vomiting, you should be very concerned with that, okay? And so what is Cushing's triad? Y'all went over that the other night with the head injuries. Has to do something with their blood pressure. What did we say their blood pressure does? It goes up. What does their heart rate do? It goes down. What do the respirations do? They can go down. Okay, very good. Okay. So, should we hyperventilate people with head trauma? Is that a good thing or bad thing?
Yes.
It's a good thing. Why is it a good thing? It causes a decrease in CO2, which causes vasodilation in the brain, or vasoconstriction, which is what we want. Vasoconstriction, very good. Now, when we say hyperventilate, does that mean just breathe as fast as you want to? What do we call it? Controlled hyperventilation, which means what? If I'm a kid and I breathe 15 times a minute, then the maximum you want to breathe from me is probably 30 times a minute. Okay, control how much you ventilate me. And remember to resuscitate hypovolemic shock aggressively. I'll tell you one thing, when it comes to kids, we're going to drill them fast. We're going to take that IO gun, that little drill gun, we're going to zap needles in their little bones as fast as we can. Okay? We want to fluid resuscitate those little guys. All right, spinal trauma. it's going to be high C-spine injuries that we see. And it says that dislocations are more common than fractures, again, because of, there you go, okay? And you should suspect if trauma involves things like sudden deceleration or head injuries, or there's a decrease in their mental status. Yeah. Some people do that. If you ask most caregivers, any given caregiver, 8 out of 10 of them will say, I do not like running on kids. Why? It hurts. One, it hurts to deal with kids, and secondly, we don't see enough of them. So what do you think our skill level is with kids? We see a lot of heart attacks, but I don't see a lot of trauma to kids, which is a good thing, okay? So again, that's not many people's strong suit, okay? Again, chest trauma is only, second only to head trauma is cause of deaths, and most of those are just because of blunt force not penetrating. And it says that rib fracture is uncommon. Remember, you guys said because of the pliability. But again, that should also tell you what?
That you're not going to be able to see the damage.
And so we should be more suspicious, right? Very good. Okay, it says they have a mobile mediastinum. That's the center part, the mediastinum, spinal area right here. So they really don't tolerate a pneumothorax very well. So they're going to decompensate from a pneumo pretty quickly, are they not? Yes, they will. And again, they don't have a whole lot of pectoralis major. They don't have a lot of chest wall muscle, which is those muscles for breathing, right? So again, they just don't have a lot of things that's in their favor when they get in trouble.
Can you get the same signs as an adult JVD and tracheal deviation in kids?
I would say yes, but the problem with them are, remember, they got a big fat head sitting what? On a set of shoulders, and most of them don't have a neck. It's very hard to detect, so those indicators aren't going to be very prominent. So I wouldn't really be looking for those before I say this kiddo's sick, okay? Again, if they get hypoxic and they got a low heart rate, you're going to be going, I'm betting this is what's going on here. All right, abdominal trauma, a couple more and then we'll give you a break. Most common pediatric form after the chest, again, usually blunt. Their organs are relatively larger and kind of placed higher in the coastal borders right here. And combine that with, they don't have a lot of muscles around their bellies either, so they have weak abdominal walls. Those things are really kind of superficial as the organs are, and they get hurt easily. Okay, so what we should be looking for in this age group are things like tenderness and distension. How many more slides do we have in this pages? 3 more slides? We'll finish this and take a break. Extremity trauma. As a rule, they're not life-threatening events, but you should pay attention to them, okay? Because blood loss is blood loss. So again, take care of the ABCs. With kids, when y'all did have y'all done the fracture stuff lecture yet? No? Y'all did musculoskeletal and bones and shit? Okay. Maybe I shouldn't use the word like that. I don't know. Anyway, y'all probably talked about green stick fracture, so you understand the concept, right? What is a green stick fracture? So the bone breaks, and what happens? Does it really break? What happens to it? Very pliable. Do y'all understand that whole green stick, why it gets the name green stick? No? All right. If I were to ask you to go outside right now and rip a limb off the tree and break it, could you break it? What's going to happen to it? It's very rubbery. It's going to go and come right back, right? And imagine that tree this time of year illustrates what? Pediatric patient. In the wintertime, that represents a geriatric patient. You take that same limb and rip it off the tree, what happens? It breaks and shatters in multiple fragments and or whatever it wants to do. So green stick is young and still growing, very pliable. So you should treat painful, tender, guard extremities as fractures. And we talked about burns. 50% of burn admissions are from kids. And what do? They're curious. They fall on stuff. They pull a pot of boiling water on top of themselves. They fall into a grate or whatever. And remember, with burns, you need to consider what? Okay, remember we talked about the stocking or glove type patterns. They look like they're wearing 2 pink socks, and that's probably a pretty good indicator of abuse. All right, great. Let's take a break.
Is that our last one for today? It should be. The only thing we do that is only 4 pages. I know, that's what I'm saying, it should be. And then when we come back, pretty sure it's private clinic.
Well, here's the thing. We breathe so much on shock symptoms in the military. I have to be excited. And I do that for training you back on. Does that make sense?
Yeah.
So a lot of it's starting to click and then the theories behind it, whereas when you're nice to know everything behind the vaccine details, you can understand theory go well like that.
Yeah. I totally got you. I think the same way. Why general knowledge matter? So you, one of the reasons why I like chemistry so much, because chemistry is not
That's my problem. That's what starts to open Iraq and Afghanistan until a photographic memory on top of it. And that's what fucked me up. So when I line situation afterwards, I sit down and study. Well, what could I have done? What could I have done this? Could I have done this? Could I have done this? Could I have done that? And again, everybody likes it. I'm the guy where I can go in on that. I think and you make a pretty good decision. Because my thoughts are far ahead. I'm great at chess because I think that's far ahead.
just sit still for 2
Hey.
Hey, honey, what are you doing?
I'm eating a sandwich in between my break at the college I'm teaching tonight. Did you call earlier?
Oh, yeah. Sorry, I don't mean to bother you.
No problem.
Well, where it was less dedicated.
Uh-huh.
By any chance, would the one that be on date on my 50th birthday in there?
You know, I remember seeing it, but I think you took it out. I think you have it. I'll look when I get home. Okay?
That's why I played house.
Mm-hmm. Are you okay? Okay. Love you too, bye.
Any other sport, I probably played it. I played baseball, I played basketball, I played soccer, I played swimming, cross country, tennis. I did it all. I played street hockey. Street hockey was fun. I was younger than that, I played street hockey quite so well. Nice. Really? Good. Seriously? That's ridiculous. Then O-line. Yeah. Usually they do those guys in
When I left high school, I ran 51 or something. Couldn't make it out of reach. That's bad.
No.
Yeah, but I couldn't get out of retail. So I'm going back to that. So I use that retail for do that at the end. So like, there. But I was in
Bitch up and down.
so we get the studies everybody else. You know what I mean? They're out of the picture, and then we start walking down.
Ow.
You start cutting everybody else, you give it 3 seconds. You know what I mean?
No, my floor real quick.
Yeah. And then when I get it, if I was 100 yards, I catch that. If he was 200 yards away, I put it away. And that's what state we got beat by. He has to state. He has to
We finished this?
Yeah.
Oh, okay.
Yes, that.
It was geriatric.
We're in 8.
Mhm.
Why is that?
I was in 800 miles. I didn't do any of that short stuff.
Okay. We'll probably be done in about 30 minutes if y'all shut the hell up. I'm kidding you. I'm kidding you. You get numb nuts to not say a word. Keep your mouth over. Keep your mouth over his hand, okay? Zibit. Nada. All right. Did you say something? Did you have to open your mouth?
You'll probably use it for you.
All right. This next to last section is the geriatric trauma we talked about. Actually, we get to talk to everybody tonight. We talked about you, the pediatrics. We'll talk about me, the geriatrics. And then we'll talk about the patient-centered influence. So we'll talk about some of y'all again.
That's only on Saturdays.
What's that?
That's only on Saturdays.
Only on Saturdays, huh?
When we go out to eat lunch.
All right. I tell you that as a population continues to grow and as time continues, the geriatric population is going to continue to grow. I mean, it's just going to grow. It's growing by leaps and bounds. So some of the things that geriatric patients are more susceptible to, we go to falls all the time of some kind, some variety. I need help getting up. Or I've fallen and I'm not sure if I'm hurt. Please evaluate me. Tell me whether I need to go. Or the obvious fall, which is they do need to go, okay? And then they're more susceptible to criminal acts too. Now, of these things that are up here, I'm not going to mention all of them, but it says that in head injuries, the increased intracranial pressure signs develop slowly. Can somebody tell me why?
Slow hyperfusion.
Okay. What else?
I said for perfusion.
Hypertension.
I don't know if I remember telling you guys, and Phil probably talked to you the other day, and he said that your brain occupies about 85% of the space within your skull. Now, as you get older, what happens to the size of your brain? It starts to atrophy, gets smaller. It only occupies about 75% of the space in your skull. So, you take an old person, hey, I'm on hypertension medications. Hey, I've had a stroke before, or I've got TIAs, and the doctor says that I need to be on blood thinners. And so I walk outside, I trip and fall, and I did hit my head on the ground. I didn't have to, I just fell. And so what happens to my brain inside my skull? It bangs back and forth. A coup contra coup injury, right? And so they develop a little venous bleed. And so we picked them up about 4 days later. It looks like they've had a stroke. What really happened to them? Combination of things, right? Brain is smaller, slapped inside their skull, has a venous bleed, They're on what? Blood thinners, and it's going to take a while for that to develop. Okay, and so we get there, and then we we start talking to family. And go, yeah, they fell about 3 days ago. Let me ask you this: an old person, can they develop an increased ICP because they sneeze real hard
Yes.
and they bruise their brain? Absolutely. So this is all we're saying is, that stuff is going to develop a lot slower.
What is that thing that they say that happens if you actually hold in your sneeze, you don't let it out? Is it the same thing? That you could burst something if you actually don't let it out and you hold it in? I don't know, I just can't remember what it was though. You haven't heard of that? No.
I'm going to go put you right next to him. You'll have to hold hands.
Why?
No, I'm kidding you. It's just a joke. It's a joke. All right. They have osteoporosis, so they are, again, at increased risk of more injuries just with trivial type things. If you look at their arthritic changes, their narrowing spinal cord, they develop things like spinal stenosis, and stenosis is a big fancy word for what? Narrowing of the opening, okay? And sudden movement may cause a cord injury without a fracture. So an old person can actually have some kind of a spinal cord injury and no bone injury at all, okay? And do old people have as much pain as we do? Generally don't. So as they get older, the chest wall becomes aged, and is it going to respond as well? Mm-mm. The respiratory reserve is also decreased, and their poor organs, which are underperfused to begin with, don't tolerate short periods of hypoxia. In this case, they're using the word anoxia, which is absence of oxygenation. Do you think an old person may have been smoking for 30 years by now? And do you think they may have developed something called COPD, which stands for chronic obstructive pulmonary disease? And of that, there's two diseases which they may get, which are chronic bronchitis and or emphysema. You bet. Their heart, again, is not working as well. It's not as strong as it used to be. And now it's pumping through what kind of blood vessels? Narrowed blood vessels, absolutely. Okay, that first one, it says hypoperfusion may occur at normotensive pressures. Trying to figure that out. Somebody help me with that.
Does it mean what they were like relaxed? Like,
Would it be like their normal blood pressure?
Well, that's what normotensive means. But it says that hypoperfusion, in other words, the cells aren't getting fed at normal looking blood pressures. Again, I would caution you and say, find out where they live, because most old people live where? They live at a hypertensive stage. So you get there and take their blood pressure, and it's what? Looks normal. It's 120 over 80, and you go, that's perfect. Is that perfect for them when they're sitting on a 160 over 90? Is their normal blood pressure? No. All right. Yep.
Could you have a patient? Old people are more prone to anemia, right?
It can be, yeah.
And so if you have an anemic patient, they're going to have less iron in their blood, and the hemoglobin won't be able to bond with the oxygen as well because hemoglobin requires iron. So would that be a cause of poor perfusion as well?
It can be.
Is there anything you could give for that, like to increase iron levels? Have them chill in there.
Not a whole lot you can do for them. Okay, and I think we've talked about this next one, have we not? Anybody tell me what that, anybody want to tackle that beast? That last bullet there?
Blood thinners. Blood pressure medication, things that balance it out, would definitely keep you from going into the shock, having the shock symptoms, the rise and fall. Kind of conceal it, especially for blood thinners out there because the heart's not working hard anymore.
No, we're going down the wrong pathway on this one. What happens sometimes as we get older, old people get their pacemakers all screwed up. And so old people sometimes develop arrhythmias, and sometimes those arrhythmias are really, really fast. In other words, they have a very fast heart rate. So the doctor may give them something called a beta blocker. And a beta blocker is designed to do what? Exactly. It's designed to slow the heart rate down. Okay, so everybody understands that part of it. Now let's say we pick up this old man who's just been involved in a car wreck, and he's got maybe a tension, a pneumothorax. So you take the vital signs and you're waiting, you're going to go, okay, I know you can tell me, I know what they're going to be before you even tell me, and I'm going to tell you his heart rate is like 120 and his respiratory rate is like 24 and his blood pressure is 130/90. He goes, you know what? His heart rate is 58. And you're thinking, what? No, what are you thinking? You're thinking, why isn't his heart rate what? Why isn't his heart rate what? Thank you. Why isn't his heart rate elevated? Shouldn't it be elevated in a normal stage of shock? But in this case, this patient's heart rate is not elevated because he's on what?
Beta blockers.
Okay, so beta blockers are keeping the heart rate from doing what? What they're supposed to do. I noticed when I was taking, when I first started my blood pressure medication, it's a beta blocker, and my max heart rate would only get so high. It kind of keeps it from going as high as it should, or as it could get. All right, you see this poor fella? It's just signs of aging, and that hunchback kind of configuration. Can anybody tell me what that is called? Big fancy word. Come on, hippie, tell me. What is that called? Anybody? None? Okay, I'll tell y'all because y'all are trying to get here in 30 minutes. It's called kyphosis. 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 Okay? So that's the curvature of the upper spine. The take-home message should be this. There's a fire department, not around here, but when they get out of school, they were told, you know what? The spine has to be on the backboard like this. So that's what you got to do. You got to tie the head to the backboard, and the back's got to be on the backboard. What do they think did? What do you think they did? Exactly what they did. They put his back and his head on the backboard, but not before breaking his back. So if you pick up this poor fellow, he's on a backboard, there's a huge distance or gap between his back and the backboard. What are you going to do? Pat it. Pat the hell out of it. Absolutely. That's normal for me. So again, I like this, and I keep telling you, I'll find out what? Where they live. And if I live with a curved spine, then transport me that way. Okay. So we know that their thermoregulatory systems aren't working as well as they used to, so they don't respond as effectively to hypo and hypothermia. Wow, that was fast.
That's when you said 30 minutes, I was like, huh?
Yep. Huh? Did you actually say huh? Is huh an acceptable word in your vocabulary? Huh?
I sometimes actually do,
I would not let my kids...
Yeah. Why not?
I would not let my kids use the word you know.
Really?
And my wife, if you've never talked to her, if she doesn't say you know 30 times in your conversation, something's wrong with her.
Wow.
Okay, I'm sorry, Jerry. Under the influence.
Yeah, we are doing it.
Okay. Wow, 10 whole slides. Okay, patients under the influence. Do you think you're going to pick up patients under the influence?
Most definitely. Yes.
Yeah, probably.
Every weekend?
Absolutely. 5 out of 10 patients you're going to pick up are going to be under some form of mind-altering whatever. Okay? So it says that roughly half of the adult trauma patients you care for will be drunk, stoned, or high. Imagine that. Okay? All right. Now, obviously, when they're under the influence, there are a lot of things that are changing with them, okay? Their mental status, their level of consciousness, their speed, everything, their vital signs, pain perception. So is there a good chance you're going to pick up somebody who's been in a car wreck and don't want to go to the hospital with you? Mm-hmm. Or is there a really good chance, okay? You think they're going to be a good historian? Mm-hmm. And you think they're going to cooperate with you? Mm-hmm. Probably not. Now this is an important bullet, that's why it's so big. It says the patient's never just drunk. So it's real easy for us to say you're acting goofy and stupid because you're drunk. But can I also have a head injury on top of that? Could also be hypoglycemic on top of that. Because they're also, yeah, and I can go on and on with that. Okay? I like this one. I really, really like this one. This one pertains to you. This should get your attention. It says that the EMT frequently determines whether the patient is cooperative or uncooperative. Do you believe that?
Yes.
Because I like it, do you have to believe it? No. Absolutely not. Now think about it. This guy just got pulled over for DWI, or he was in a car wreck, and he's probably going to get arrested, all that kind of stuff. And so the cops been giving him a hard time because it's what he's supposed to do. And you walk up, and this cop is your buddy, and this guy's pissed off and cussing at the cop. It's real easy to do what? It's real easy to start defending your buddy and acting the same way toward the patient as the cop was. And I'm not saying cops are bad people. Don't get me wrong. I love cops, okay? All I'm saying is we're not playing that role. Our job is to take care of you. And our job is to not clump everybody into one category. Our job is to say, you know what, maybe the reason you got drunk is because your wife left you, or you just found out your 18-year-old daughter is pregnant. You know, there's got to be a reason, and maybe there's not a good reason. So I try to take that into consideration before I just start jumping on the bandwagon and go, yeah, I'm going to treat you like a jerk too. Okay? So some of the things that you can do are you can be positive. I mean, now's not the time to say, hey, bud. I hate that. I hate when people, you know, especially when I get there first and I call somebody by their name, find out their name and all that kind of stuff, and the medic comes up and I said, this is Mr. Johnson. He goes, hey, bud, what's going on? Where did Bud come from? His name's not Bud. Okay? Again, don't be judgmental. You don't know what's going on in their life. You don't know why they're acting the way they're acting and why they've taken these drastic measures or whatever. It's important to identify yourself. You still need to do things like get permission to make contact and orient them and reorient them as needed, because they're going to be probably not on top of their game, and they could have a head injury on top of that too. Remember, consider your body language and your vocal tones, and you're not your caregiver, not a cop. We mentioned that. You should acknowledge their feelings and their concerns. Am I going to be arrested? Am I under arrest? I don't know. I think the police officer said you're in custody. Whatever, okay? I like that last one. It says, be very clear about what you need and expect the patients to do. This guy starts groping your female partner. Is that acceptable?
No.
Totally not acceptable. He starts cursing at you. Not acceptable. He starts spitting. Not acceptable. So those unacceptable things, you need to set the guidelines. And usually when I have somebody that the cop's already pissed off or life's already been pissed off, and you get there too, you know, and they carry back on, they're carrying on, they're cussing at you, go, look, I understand you're having a tough deal. I'm not exactly sure what's going on here. I said, but that's not going to help either one of us. You don't need to be talking like that. And I'd appreciate it if you don't talk to me and my partner like that. And I need you to keep your hands to yourself. And most of the time, they will fix that. They'll behave themselves. Sometimes you have to remind them, well, that's okay too. You really want to ask open-ended questions to a drunk person?
No.
No, you just want simple, does your neck hurt? No, it doesn't. Okay, don't. Have you ever had any problems with your neck? Well, yeah, I remember. No, because they'll keep talking. And should you kind of converse with the family and match the histories of what they say happened and what actually happened and things like that? Not a bad idea. All right. Remember, with uncooperative patients, you need to pre-plan the protocols with your local law enforcement agencies, what you're going to do, what they expect you to do, what happens if they get overwhelmed and they need your help and stuff like that. So again, we're kind of helping each other. Remember, this population is a high risk for, the following problems. Okay, I really think you should err on the side of caution with these patients, especially these intoxicated patients. It's real easy, and I really wish they'd take the word intoxicated out. Why?
Because it could be that they're not intoxicated.
And what else? If I am the opposing attorney and I'm taking you to jail and go, what's intoxicated? Well, the law says that if you're 0.08 alcohol, okay, where's your blood test? What kind of test did you just take to determine they were intoxicated? You see where I'm going with this? So it's really kind of difficult. Wow, that was fast.
For like your narrative, would you put under the influence?
Nope. I would not put under the influence. Why?
Just another word for intoxicated.
Uh-huh.
How would you recommend conveying that kind of information? Possibly under the influence, or add some...
You can say, if the patient has said to you, I've had 6 beers. Okay, doc, he had 6 beers. You determine whether you think he's drunk. It's not my... I'm just telling you, he said he had drink, or he's been drinking all day. You know what I'm saying? The bet is you're probably, I want to call you drunk, and we know you're drunk, but guess what? I'm not going to call you drunk. I'm just going to tell me what you drunk.
Can we ask him if he's been drinking?
Sure you can. There's nothing wrong with that. But what do you think they're going to most likely tell you, though? No. No. They will tell you that I'm drinking. But what will they tell you? How much you had? 2 beers. You watch. You mark what I say.